Hello students, today I'll be discussing a topic on varicose veins. So the outline of the talk will be what is the definition of varicose vein, how do you define varicose veins, what is the venous anatomy and the physiological pump in the lower limb, what is the etiopathogenesis, what are the clinical features with which patient presents to you, clinical examinations, what are the necessary investigation which you want to do, and finally the treatment, the medical and the surgical treatment which you can have for a varicose veins. So coming to the definition, what is varicose veins? Varicose veins is defined as first is dilated, elongated and tortuous superficial veins of the lower limb. Mind it should be dilated, important word, elongated, and has to have tortuosity, then only called as a varicose vein or pathological veins. It is usually due to the permanent loss of the valvular mechanism that is present into the veins, which leads to venous hypertension in the lower limb, and thus patient manifests with the symptoms of the varicose veins. Now coming to the venous anatomy of the limb. Venous anatomy comprises of three components. One is something called as superficial venous system. As the name suggests, it lies superficial to the fascia. Then you have a deep venous system, and third is the perforator veins. Perforator veins are the veins that connect the superficial venous system to the deeper venous system. Superficial venous system, it lies just beneath the skin and superficial to the superficial fascia, and it comprises of two main veins. One is long saphenous vein, also called as great saphenous vein, and second is the short saphenous vein in the lower limb. Long saphenous vein has a very long course that starts from the medial arch of the lower limb, passes anterior to the medial malleolus over the distal third of the leg, and it is accompanied by saphenous nerve below the knee joint. This relation is very important when you're doing a surgery. In thigh, it passes anterior superiorly to reach the SF junction and opens into the SF junction, that is in the femoral vein, approximately 3.5 centimeter below and lateral to the pubic tubercle. So here somewhere here is the pubic tubercle. It is 3.75 centimeters lateral to the pubic tubercle. It opens and forms the SF junction. Next superficial vein is the short saphenous vein. It arises from the dorsal venous arch but from lateral end of the dorsal venous arch, whereas the long saphenous vein arises from the medial part of the dorsal venous arch. It passes behind the lateral malleolus and runs in midline posteriorly into the interfacial compartment, pierces the deep fascia in the part of the upper calf muscles, and then finally it terminates into the popliteal vein, that is the vein in which it drains. The location of the saphenopopliteal junction is variable. It is not fixed. It can be at the knee joint, it can be up to above the knee joint, it can be slightly below the knee joint. Important relation you should note is with the sural nerve. In the entire course of the short saphenous vein, it is accompanied by a nerve called as sural nerve. Next system, that is the deep venous system. It comprises of femoral vein in the groin region. Then it descends into the popliteal vein, anterior tibial vein, posterior tibial vein, and there are valveless vein system into the calf muscle, gastrocnemius and soleus. They don't have the valves. It approximately carries almost 90 to 95% of the venous return towards the heart of the lower limb. So most of the blood from the lower limb is carried by the deep venous system. Only 5%, 5 to 10% of your blood from the lower limb is transmitted or carried towards the heart via the superficial venous system, that is long and the short saphenous vein. It is connected with the superficial venous system by the plexus of or something called as channels that are called as perforators. Perforators. Perforators are the communication or connection between the superficial venous system and the deep venous system. They traverse through the opening in the deep fascia and enter the deep veins. The direction of the flow in the normal condition is always from the superficial to the deep. That is, this is the superficial venous system. This is the deep venous system. These are the perforators. So the blood will normally travel in from the superficial venous system towards the deep venous system. But in a case of varicose veins, this physiology is reversed. Now the blood has started going through through the deep venous system towards the superficial venous system because of the incompetent perforators. So these perforators are usually guarded by the valves that are unidirectional. That is, they allow flow from the deep to the superficial system. But perforators, there are as much as 20 to 30 perforators in your lower layer. They have variable positions and locations, but there are few named perforators there are which are constant in their position. One is Hunter canal perforator, that is usually present in the mid thigh region, that is around the Hunter canal region area. Next is Doyd perforator, that is approximately palm breadth above the knee joint. Third perforator is Boyd perforator, that is present just below the knee joint. Fourth group of perforator is ankle, or also called as lower leg perforators of cockets. There are three in number: cocket 1, cocket 2, cocket 3 group. They are pretty constant in their locations. They are approximately 5 centimeters above the medial malleolus, 10 centimeter above the medial malleolus, and 15 centimeter above the medial malleolus. Etiology. Etiology of varicose veins can be primary or secondary. Primary is when there is no pathology that causes varicose veins. So one is congenital anomaly into the vein, that is something called as Krippel-Trawny syndrome. In this syndrome, you may have an arterial pathology or a venous pathology. So if it is having a venous pathology, the vein become valveless. There is no valve, so the flow of the veins have been reversed, and the patient may present to you with dilated tortuous veins over the lower limb and indirectly varicose veins. Next is acquired cause. Acquired cause, people or patients who have a history of prolonged standing, for example, soldiers, watchmen, ironmen, and even surgeons, history of prolonged standing at a single point that will lead to development of venous hypertension in the lower limb because of the valvular insufficiency, mostly at the SF junction, commonly at the SF junction. So mostly people who have a history of prolonged standing, as in this, will have a venous hypertension. That is because of the SFJ, that is femoral junction, that is constant under constant pressure, constant reflux, and that valve becomes incompetent. Secondary causes is when there is pathology in the vein proper. There is some pathology, as in patient had a DVT, patient has a DVT, or he had a DVT because of which the vein has become problematic, fibrotic, so it is not functioning properly, not dilating, not the valves of the veins has been destroyed. So it is DVT and its sequelae. This is seen basically in patients who have a history of prolonged immobility, as in patient has a pregnancy, trauma, major surgery, or ICU patient who are chronically bedridden. So those patients will have chances of developing a DVT, and as a sequelae of DVT, patient may develop a secondary varicose veins into the leg. So what is the sequence? Patient may develop a thrombosis into the deep venous system. This thrombosis will lead to the fibrosis, inflammation and fibrosis in the vein, and this fibrosis eventually will lead to the inelastic valves, and the valves are destroyed. So example, patient is having any risk factors or causes, as in primary or a secondary varicose veins. This will lead to the increased venous pressure into the deep venous system. So the valve becomes stretchy, and this stretched valve becomes incompetent over time, and there is a reversal of blood flow from deep system to the superficial system, which is normally not there, and the superficial veins becomes dilated, and then patient will present to you the varicosities, and it's called as varicose veins and its complication. Now coming to the classification, how do you classify the varicose veins? There is something called as CEAP classification or a SEEP classification. Basically, it's a combination of 4 classification. C for clinical classification, that is how the vein is appearing, appearance of the vein. Second is etiological classification, that is E, that is what is the cause, why did these varicose veins occur. Third is anatomical, which type of vein it is involving, whether it is involving the superficial venous system or deep venous system, or it is involving the perforator system. And P, that is pathophysiology, what is the cause, what is the changes that has occurred in the vein that has led to the varicose vein formation. So this is the types of varicose veins. So in a clinical classification, you label it from C0 to C6. C0 is no visible or palpable vein, that is no varicose veins. C1 is when you have a telangiectasia or a reticular vein, that is a prominent vein that you can see. You can see in this picture, you can see this small reticular, very thread-like or spider leg-like appearances. C2 is a proper varicose vein formation, when then you have more than 3 mm dilated veins over the limb with tortuosity and dilatation, then it is called as a proper varicose veins. C3 is edema, having a varicose vein plus you have a lower limb edema, lower third leg edema. C4A, pigmentation or plus minus eczema, then maybe a pigmentation, lower third of the leg is pigmented. C4B, when patient have changes of lipodermatosclerosis or atrophy of the limb or the skin in the leg. C5 is patient had an ulcer in the past history but it has healed. There was an ulcer, very venous ulcer, but it has healed. And C6, when there is open active venous ulcer that is not healing over time, is called as open venous ulcer. Next, E classification. What is the etiology? Whether the vein is congenital, patient is not having any problem into the vein, but the pathology is congenital, as in a triple Townes syndrome. EP, that is, there is a primary pathology, that means patient is having a history of prolonged standing, as in watchmen, fishermen, surgeons. So that has led to the incompetence of the superficial venous system, that is the SFJ. Secondary ES, that is, it is because of some thrombosis that has occurred into the vein, that is DVT, which has led to the fibrosis and the valve has become incompetent. And EN, that is no pathology that can be detected, no such history is there, there is no relevant finding that you have on the etiology basis. A, anatomical classification. Anatomical classification you have divided into three. Which part of the vein is involved? Whether it is involving the superficial venous system, then you will write it as a AS. If it is involving the perforator vein system, only any of the perforator group of perforators is incompetent, you write it as AP. If it is involving the deep venous system, there is thrombosis in the deep venous system, then you write it as AD. And if there is no cause identified, no anatomical location identified, but patient is still having a venous ulcer over the leg and other symptoms of the varicose vein, then you label it as a AN. Last, the pathophysiological classification, that is P. If patient is having some reflux disease, as in history of prolonged standing, that is leading to the reflux of blood from the deep venous system into superficial venous system, then you write it as a PR. And if it is because of obstruction, that is there is active thrombus into your deep venous system that has led to the dilatation of the superficial veins, then you write it as PO. If the pathology is the combination of the reflux and the obstruction pathology, or that is the primary and the secondary, then you write it as a RO. And if the cause is not identifiable, you write it as a PN. So for example, if I am giving you a diagnosis of patient is having a varicose vein with C2, EP, AS and PR, that suggests patient is having a dilated veins, that is proper varicose veins. The pathology is primary, that is patient history has some history of prolonged standing, and as the vein is visible, it is involving the superficial venous system, and as P is R, that is reflux disease, that means there is a reflux of the blood from the deep venous system, from the femoral vein into the superficial venous system, and the patient is having this symptom. So this is CEAP classification. Normally you should have or you should apply this to your diagnosis, but normally not practice because it is very tedious to remember. Now coming to the symptomatology, what are the symptoms with which patient presents to you? First and the foremost common symptoms with which patient presents to you is dilated veins over the leg. That is the most common presentation. You can see there are dilated veins that is present over the limb. This is the most common presentation with which patient comes to you. Second is there is dragging, dull aching pain over the lower limb and preferably in the evening time. There may be an edema on the ipsilateral limb pathological side. There may be development of ulcer, eczema, dermatitis, and bleeding. Pruritus can also be there. There may be a night cramp, and finally there will be a skin above the ankle may shrink and the fat under this is lost and the limb becomes very hard. Coming to the examination. So, first part of the examination is inspection. It should always be done in a standing position. Make the patient stand and you have to go at the level of his leg and try to observe any finding. So, first thing you may notice is dilated vein there, that is present. You should note whether the vein which is dilated is present medially of the middle side of the leg or towards the lateral aspect. That will tell you which type of vein, whether it is a long saphenous vein course or a short saphenous vein course is present. You need to see any single dilated varix that is present over the SF junction, that is 3.75 approximately 4 centimeter lateral and inferiorly towards the to the pubic tubercle. So is there any obvious swelling that is giving you a cuff impulse positive? Third is local blowout. Any local blowout or local swelling that is seen over the lower limb, whether it is in the long saphenous vein course or a short saphenous one, that suggests you or tells you whether which perforator is incompetent. Next presentation is patient presenting to you with a non-healing, chronic non-healing ulcer, or there are multiple healed ulcer and patient is recurrently developing ulcers over the lower limb.